Let's make a start. Can you hear? Is it there? Can you hear me? Great, let's make a start. Is it on? Okay, so for those of you who don't know me, my name is Aziz, Sheikh, and I've got the privilege of being the director of this absolutely fantastic Usher Institute. And on behalf of the Usher, it's a real pleasure to welcome you to this fabulous hall and to today's Usher Institute Annual Lecture 2023. Absolutely delighted that we've got, and it's a sellout in person, and we've got loads of colleagues joining online, so a very warm welcome to all of you. We've got colleagues joining from across Scotland, the UK, Europe, Asia, Africa, and North America. And particularly pleased that what we've got are sort of people coming from all sorts of backgrounds. So NHS colleagues, public health practitioners, leaders. We've also got, of course, our government colleagues as well, and that's absolutely fantastic, as well as academic colleagues from across this university and many other universities. So a very warm welcome to all of you, but in particular, I'd like to welcome Susan Hopkins, an absolutely wonderful colleague who's the Chief Medical Advisor of the UK Health Security Agency. And also Paul Johnston, another wonderful colleague who's recently taken up position as the Chief Executive of Public Health Scotland. So two fantastically important organisations. And you'll hear more about Susan, who's our lecturer for this year, and Paul, who's going to give the response to the lecture in due course from Linda Bauld. I want to tell you a bit about the Usher, for those of you who don't know. So the Usher was first set up in 1902, so it's an old institution. It was created to coincide with the creation of the world's first academic chair in public health. So this university gave the world academic public health, and it's a real sort of opportunity to celebrate that today, I think. What we have had subsequently is that the Usher has evolved. These things do need to evolve, and what we've had is that first fused with academic primary care, and again, Edinburgh led the world in this respect, creating the world's first academic chair of primary care. So those two came together to create a grouping of population health, which is now led by Linda Bauld and David Weller. But what we've also done is brought in colleagues really from a whole range of other disciplines. So science and engineering, we've got computer scientists, machine learners, for example, as part of the Usher. We've got the whole range of social sciences represented, sociology, anthropology, law, ethics, absolutely fantastic contributions, for example. We've got medical informatics, we've got global health, we've got considerable expertise in clinical trials. So this is really now sort of a microcosm of this university in terms of the disciplinary mix that we've got, and it's really, incredibly sort of stimulating, vibrant environment in which to have the privilege to work. The way we view ourselves is as sort of the main applied translational axis in matters relation to sort of the NHS, healthcare delivery internationally, public health, and with policymakers. And so we have a number of colleagues who are seconded into roles really with government entities and funding agencies, for example, both in Scotland and the UK, but also internationally. A number of those colleagues are here. So I think really, interesting sort of positioning, I think, so that kind of diversity of experience and expertise, but also those relationships, I think, position us really well going forward. I hope some of you guys have had the chance to look at some of the, it's only a really snapshot of some of the work that's going on in the showcase that was presented downstairs. And for colleagues joining online, some of this material is also available to you. We'll also hear from some colleagues giving some short presentations about some aspects of this work. This hall is, I'm sure you agree, it's absolutely stunning. I mean, I'm kind of stunned every time I come in here. So first created in 1897, it's a Grade A listed building and has recently been absolutely beautifully renovated. What you'll see if you look up, for those of you who have the privilege of being here, there are these absolutely beautiful murals. There are 15 of these that represent the science and the arts. There's also actually a beautiful kind of inscription at the top as well that you may be able to see. So it's from Proverbs. So wisdom is the principal thing, therefore get wisdom. And with all thy getting, get understanding. Exalt her, and she shall bring thee to honor. So that's what we're trying to do, because what we're sort of grappling with today is something that, I mean, has affected and is continuing to affect sort of so many people, I mean, all of us, I mean, globally. But we've got to sort of position ourselves better going forward. And I think these are challenging issues, but I mean, I think absolutely delighted that we've got a fantastic lecturer and responder to help us think through some of these issues for Scotland, for the UK, and for the world. I want to just now turn briefly to the Usher Institute annual lecture. So this was started 8 years ago now, and it was first kicked off by Professor John Ioannidis from Stanford. So John chairs the Scientific Advisory Board for the Usher, a wonderful colleague. The second one was given by Professor David Blumenthal, one of the world's leading health policy experts, and at the time the president of the Commonwealth Fund in New York. We then moved to Chris Whitty, now Sir Chris Whitty. I think we all know Sir Chris, really. And Chris gave us an absolutely kind of a fantastic lecture. Then we had Victor Zhao, who leads the National Academy of Medicine, another wonderful colleague bringing, I mean, a real international dimension to the work. Then we had Jeannie Chavaler from UCB in Canada, absolutely fantastic. Martin Landry, or now Sir Martin Landry, led the recovery trial from the University of Oxford. And then last year it was Fiona Godley, the former Register-in-Chief of the BMJ, talked about sustainability considerations, clearly something in the news this morning as well. Susan, you're in incredibly sort of privileged company and absolutely delighted that you're joining this list of Usher lecturers. So just finally, I mean, I've got a bit of housekeeping to do, and so please do just take a moment to scan this QR code so you can access the Usher Institute Annual Lecture and Showcase website, because this is the vehicle by which we'll be taking questions, and Linda will tell you more about that in due course. It's also an opportunity to see the showcase and in due course give us feedback about this. There are kind of a variety of tools there, so please do go and have a look at those. Finally, I mean, I don't think there's any more sort of fire alarms scheduled. For those of you who were here earlier, there was one that went off, but I hope there's nothing scheduled going forward. So just on that note, it's an incredible honor to hand you over to Professor Linda Bauld. Linda is the co-director of our Centre for Population Health Sciences. She holds the oldest chair of public health in the world, the Bruce and John Usher Chair of Public Health, and she's also the Chief Social Policy Advisor to the Scottish Government, and an absolutely wonderful colleague. So Linda, over to you. Thanks so much.
Well, just to add my very warm welcome to Aziz. It's absolutely wonderful to see you, and a particularly warm welcome to Susan and Paul. So for the next few minutes, I'm going to introduce the Usher Showcase, which is some short presentations to give you a sense of the range of excellent research that happens across our institute. So each presenter, this is a challenge, will have 5 minutes to speak. There won't be the invisible umbrella coming on the side of the stage to yank them off if they go a little bit over, but I know they will stick to time. And then, of course, you will have a chance to ask questions using Slido. So as you listen to these 4 speakers, please think of a question or two and put it on the Slido. So I'm delighted in the first instance to introduce Dr. Gwenetta Curry. She's a reader here in Usher, and she's going to talk about racial and ethnic inequalities in the UK and the impact of the COVID-19 pandemic. Gwenetta.
Hello, everyone. Thank you for the introduction, Linda. So yes, I have 5 minutes to kind of go through a lot of information, but let's kind of set the stage. We're going to talk about racial and ethnic inequalities across the UK prior to the pandemic. A lot of people focus on the pandemic and say, oh, the pandemic has made it, terrible, but it wasn't so great for all groups prior to the pandemic, so it's important to keep that in mind. So this first slide goes through housing. So Black, African, and Arab groups had the lowest rate of home ownership compared to their white counterparts at 68%, white British. The reason this matters is that when you talk about generational wealth and health, these things are directly connected to one another. Where we live can determine our opportunities as well as have a large impact on our health, dealing with the environment around where you live. Education. Education has been seen as, the way forward, the way to improve your life, to improve your health, and your overall opportunities. Well, the data shows that mixed white and Black Caribbean pupils were nearly 3 times as likely to be permanently excluded than their white counterparts, right? So these are some of the things that were existing prior to COVID. So just put that in terms of when we think about opportunities that people have. If you take them out of the educational setting, what opportunities do they have to get a sustainable job, to live in adequate housing? All of these things kind of build on one another to create a more disadvantaged group. Lastly, unemployment. Black people had the highest unemployment rates of all ethnic groups in the UK. Now, this is data from ONS. This is the Office of National Statistics. And again, this is prior to the pandemic. So I work with an amazing research team called Uncover that was created during the pandemic to do systematic reviews. It's co-led by Ruth and Evie. They're amazing scientists that, they came together and said that, what can we do to contribute under the pandemic? And we conduct rapid systematic reviews for various groups, the Scottish Government as well as the World Health Organization. And during the pandemic, we created high levels of evidence to kind of help guide policymakers to understand what is the best data that we have right now. Everyone was searching around trying to say, okay, is this the right direction? If not, we were not there to tell them where to go, but we were there to provide evidence of what's been done in other locations and, the way that some people were using it that could be used also in Scotland. So as the inequalities expert, I focused on racial and ethnic inequalities, and this is one of the reports that we published was what's the evidence on ethnic variations in COVID-19 incidence and outcomes. And what the data showed is that Black, Asian, minority ethnic populations experienced the highest rate of mortality during the COVID pandemic. And we were really trying to investigate why this was happening. So we looked at comorbidities and where people were working and where people were living, and we found that there's a lot of overlap between where people work and live and their chances of contracting COVID-19 as well as the severe reaction to COVID-19. We are currently working on investigating the impact of policies. So in the beginning, we created systematic reviews to kind of inform policymakers and different groups about evidence, but now we're looking at, during the pandemic, what policies were put in place and how do they advantage or disadvantage certain groups. So that's some of the work that we're doing right now, and there's a great poster as well downstairs if you have time to take a look. But the takeaway message is really around there's a lot of work left to be done on racial and ethnic inequalities and improving the data that we currently have throughout Scotland and throughout the UK. If you know from my voice, I'm from the US, yeah. And so a lot of times we look at the comparison of how the data are presented there versus presented here, and there's some learning I think that we can do in terms of being transparent about what the data is actually showing and giving some, suggestions and direction. Thank you very much.
Thank you, Gwenetta. And now I'm delighted to introduce my colleague, Professor Harish Nair, who's Professor of Pediatric Infectious Diseases and Global Health. He's also co-head of the Center for Global Health. Harish.
Thank you for the introduction, Linda. So I'm going to talk about setting research priorities for global pandemic preparedness and compare the outputs of an international consensus expert group exercise with ChatGPT's output. And I'm doing this presentation on behalf of my colleagues Igor Rudan and Davies Adeloye, who really led this work. So what we did over here was that we used the Child Health Nutrition Research Initiative method to identify research priorities for future pandemic preparedness. Now, the CHINRI method is a systematic, democratic, and transparent way of research priority setting that has been used in over 130 research priority setting exercises by national governments, by funding bodies, by international agencies like the WHO and the UNICEF. So it's really well accepted. And for this particular exercise, which was done as part of the International Society for Global Health, we wrote out to about 1,000 members of the International Society of Global Health, inviting them to submit their research ideas. And of these 1,000, over 80 experts responded back with 163 ideas, and these experts were all from diverse backgrounds. Some were from global health, others were from translational and clinical research. And then a core group of 42 researchers scored these research ideas based on 5 predefined criteria. That is feasibility and answerability, impact on burden reduction, potential for paradigm shift, potential for translation and implementation, and impact on equity. We then asked ChatGPT to define and list in order of importance the greatest research priorities for global pandemic preparedness. And why did we do that? We know that the ChatGPT or any of the AI software, they use all available knowledge on the internet, and therefore that eliminates any kind of bias, for example, selection bias or participation bias, response bias, that may still exist within any of these expert consensus methods like the CHINRI or the Delphi method. So what did we find? The top research priority that was identified by the CHINRI method, which was rapid development and accelerated approval and rollout of vaccines and antivirals, was also returned as one of the top 2 priorities by the ChatGPT. The second priority of the CHINRI exercise on the role of WHO and other international organizations, however, did not feature prominently in the ChatGPT's outputs, although it was sort of captured more broadly within the 8th priority for ChatGPT. The third priority for both ChatGPT as well as for CHINRI were identical, and that was surveillance and early detection. The next identified research priorities by CHINRI was around concerns around supply chain management and health systems capacity, and this was captured broadly in ChatGPT's 4th priority. Then ChatGPT ranked the One Health approach and the tracing of pathogens genomically across species as with their 5th and 7th priority, whereas for CHINRI, this was much lower. It was ranked 20th more specifically and 5th more generally. Both the CHINRI method and the ChatGPT placed value to behavioral and social sciences in the pandemic. ChatGPT ranked it as a 6th priority, whereas the CHINRI exercise ranked it in the 13th and 15th priorities. The priority that was ranked 11th through 13th by ChatGPT that included risk communication and misinformation, innovative technologies and ethical considerations, that was also captured within the top 20 CHINRI priorities. ChatGPT ranked economic and social impact analysis as their 14th priority. This, however, did not feature in the top 20 CHINRI priorities. So in summary, both the human output as well as the AI-based outputs showed that the 14 leading priorities that are identified by the ChatGPT are often similar to the 20 leading priorities identified through the CHINRI method. So there is quite a good complementarity there. But what we found was, while where the rankings diverged, the ChatGPT's research priorities appeared to be more predictable and grounded in theoretical knowledge compared to the CHINRI process, which was more nuanced and guided by recent practical experiences. And it shows that the CHINRI method based on crowdsourcing is indeed robust and is supported by the AI tool. And this is an early example of how we could use the human collective knowledge and opinion as well as the AI tools to strengthen confidence in research priority setting, particularly when both these are intended towards influencing policies. Thank you.
Thank you, Harish. And next, I'd like to introduce Dr. Katie Atkins, who's a Chancellor's Fellow and Reader. Katie.
Thanks, Linda. Hi, I'm Katie, and I'm an infectious disease epidemiologist here in the Usher Institute. So I'd like to speak to you about the silent pandemic of antimicrobial resistance, which causes around 1.3 million deaths per year. So we know that resistance management is always going to be better than scaling up the production of new drugs. But obviously the question is, how do we do this? So we have two options. Either we can reduce antimicrobial use, or we can reduce the number of bacterial infections. So the O'Neill report suggested ways in which we can accomplish both of these strategies. And it's important to point out here that reducing the number of bacterial infections will actually have a knock-on impact of reducing antimicrobial use, and thereby reducing the selection pressure for resistance. So we're particularly interested in using vaccines to support this effort. And I think it's important to point out there's been quite a lot of empirical and theoretical data suggesting that vaccines are not as susceptible to evolutionary pressure as antibiotics are. So they might be a good option. So I'm going to talk briefly about our work and the principle for pneumococcal conjugate vaccines. So this is really important because pneumococcal conjugate vaccines, or PCVs, prevent pneumococcal infection, which is the leading cause of childhood pneumonia. So we have some evidence that these vaccines reduce antimicrobial use quite modestly at around 7% in those children who take PCV compared to those who don't. But the broader question of actually whether PCVs reduce antibiotic resistance, antimicrobial resistance, is kind of unclear. And I would argue that it's unclear because we have a lack of control studies really disentangling the effects of the vaccine from the effects concurrent that you get in the background, right? So we struggle with a lack of data. So to circumvent this, we thought we'd do some modeling. I'm a mathematical modeler. And actually, our preliminary work raised more questions than it answered. So I'm showing here a graph where we're modeling the resistance prevalence in pneumococcus. And we see that over time, after the introduction of a PCV, we get hugely diverging predictions, ranging from the vaccine being terribly effective and reducing resistance prevalence to almost zero, to the vaccine doubling the resistance prevalence, which is obviously a terrible outcome. So the difference between these lines is how we encode the assumptions around resistance transmission. So our fundamental knowledge of epidemiology of resistance transmission. So the mathematical models did not help us. So we had to go and get some more data. So we've decided to use a cluster randomized trial, here shown in Trang in Vietnam, and specifically use resistance as an endpoint of the trial. Okay, so we're going to be getting data on, over time, what are the resistance prevalences in vaccinated clusters and unvaccinated clusters over 1, 2, 3, 4 years post PCV introduction. So we'll be able to understand the effectiveness of a vaccine in directly reducing resistance. But the cool thing about this is once we've got the data, we can then match it to our predictions on the left-hand side in the mathematical modeling plot and say, okay, we can predict both the medium-term impact, but this can give us fundamental information about what we believe about the epidemiology of resistance transmission. So we can get a better model, which will be able to give us longer-term predictions about the impact of PCVs on resistance to hopefully inform public health, and that's what my group's working on at the moment. Thank you.
Thank you, Katie. And finally, last but by no means least, Professor Alasdair MacLullich, who's Professor of Geriatric Medicine.
Thank you. Thanks so much. It's really exciting to be part of this amazing event. So one of the features of the pandemic that really struck me was just the sheer complexity, that of the challenges that presented, across the board, from the medical challenges, nursing, healthcare challenges, developing vaccines, policy, to do with education and work. And there was so much information coming, and this barrage of information meant that some stories were more prominent, some problems in how we handled it were more prominent than others. So today I'm going to be focusing on 3 areas which I think were not perhaps covered all that prominently, despite the fact that they affected large numbers of people and were very important. And these 3 areas are delirium, hip fracture care, and the effect of lockdowns, all on older people. So delirium is a condition where people become acutely confused over hours to days. It usually only lasts a few days, but it can persist. And people with delirium can be confused, they can be sleep or agitated, but they can also have horrifying experiences. These are figures from people who've experienced delirium, and somebody wrote this during an episode showing the level of suffering that it can cause. Delirium is triggered typically by things outside the brain, so infections, surgery can do it, drugs. It's a really common problem. It's much more common in older people, but it's in the hospital I work in, the Royal Infirmary in Edinburgh, which has about 1,000 beds, around 150 to 200 people will have delirium at any one point. So it's an extremely common, serious problem. This is pre-pandemic. And the treatment is focused on 2 key areas: to address what we think the causes are and to manage the symptoms. So when COVID appeared, the approach to offering tests, which of course were rare and hard to get at the beginning, was to focus on these 2 typical symptoms of infection, of fever and persistent cough. But it quickly became apparent that older people were not presenting typically, and delirium was actually a very common feature. And this triggered the study you see on the right there, and I'm the first co-author, Rose Penfold. It's a London-based study, but Rose is now working here in the Usher and has a poster today on a different topic, but pleased to have Rose here. And this was a very important study that showed that in older people, delirium was a common presenting features of COVID, and this led to a change in government policy as to who was offered the test. So it was an important change that led from this piece of science. Another thing about delirium was how common it was and how serious it was in COVID. And it was very distressing for those of you who work clinically, to see this, with people. The death rates were high, and people often had terrible delirium during that time, and this led to the need for new guidance, which many of us around the UK produced there. Another area that was very disrupted by COVID was hip fracture. So it's a common condition. About 8,000 people a year get it in Scotland, and it requires a lot of care from a huge team of people, physios, OTs, doctors, nurses, to get people through the operation and out with as much pre-function mobilization restored as possible. In Scotland, we have good hip factor care. We have a set of standards that's audited by the government, and that helps to ensure that. When COVID happened, it triggered huge changes in workforce with people being redeployed. I was one of those people redeployed to a COVID ward, and it was kind of necessary. Also, a lot of people were off sick with COVID, and this had measurable effects on hip factor care with operative delays, less physiotherapy, and that affected the trajectory of older people in hospital. Another serious consequence was direct, in that people with COVID and hip factor had very high mortality rates of 35% at 30 days compared to the usual 7%. So it was really devastating. And on the bright side, we noticed that in some recent research that vaccinated patients had less severe COVID, but actually almost at the same level as people who didn't get it at all. So that showed the value of the vaccines. Finally, I'll just talk about lockdowns, and of course these were considered to be necessary at the time and were necessary probably to protect, but studies have now shown just how devastating these were on people living at home but also living in care homes, with multiple effects on mental health and physical health as demonstrated there. And so I think this is something that we really need to think about in the future, is the kind of collateral damage that can happen when we make these policy shifts, and how to anticipate that for the future. So there's many conclusions that one could draw. I think this is a reminder that older people, especially when they're very old and frail, can respond very differently to acute illnesses. It doesn't look like what you'd expect in a 45-year-old, and the typical symptoms may not apply. And also the vulnerability of older people, with much higher mortality rates, which we saw during the pandemic. So many lessons. Here are some of them I've cherry-picked. So I think maybe the key message is research is very important. It makes a huge difference to what we do. It affects policy. But let's be more proactive about incorporating older people into research should there be another pandemic. An example of where this really worked was the UK-led recovery trial, which had no age limit, and it had a very big effect on our practice. And isn't it great that we were able to offer those treatments to old, frail people because we knew that they worked, because they weren't excluded from trials. Let's consider the whole pathway from the presentation, but also the experience of people in hospital, and as they go out, the knock-on effects, especially when you're vulnerable, can be very big. Let's not forget about care homes. I'm not saying we did forget about them, but I think they need to be at the front and centre, because 300,000 of our citizens in the UK live in a care home. That's their home. How we look after them in the care homes, all the special constraints of that. It's also a critical area that we must not be slow to catch up on like we were with this pandemic. And also that, of course, we need to protect people from infection, but when there are going to be harms associated with those measures, that we try and mitigate those and anticipate them in some way. Thanks very much.
So many thanks to the colleagues who put questions on Slido. That's great. So we've got 5 minutes just for a few quick-fire questions. We've just got one microphone, colleagues, I think, between the four of you. So Katie, first a question for you. How is vaccine hesitancy factored into or incorporated into your models? And are these issues comparable across high and low-income countries? So is that the kind of phenomenon that you can think about incorporating into a model?
Yeah, thanks very much. So there's people separately doing great work on sort of psychology of vaccine hesitancy, and I'm not going to speak on their behalf, but certainly we have to incorporate some knowledge of the vaccine coverage within the models. And it's actually one thing that we've seen in the models is the kind of equity issue. So the vaccine, and I'm talking in the context of pneumococcal conjugate vaccines, but if we have a situation where some people are vaccinated and some people are not, that vaccine is going to change the epidemiology of the disease. So if we are in a situation, an unhappy situation, when, in our case, a vaccine might increase the relative frequency of resistance in the population, that's going to be fine if you're nicely protected from the disease. But if you're not, that's an equity issue, because you're basically increasing the burden of resistance on those who aren't vaccinated. So vaccine uptake is a huge issue that we have to absolutely take into account in the models and in our public health interventions that we introduce to in the context of both resistance and more generally disease burden. Thanks.
Thanks, Katie. And a question for Gwenetta. Were these racial and ethnic inequalities observed to the same extent in other countries during the pandemic? And are there any differences by sex and gender?
Thank you for the question. So I would say the closest country that mirrored some of our outcomes was America in particular, following down, racial and ethnic lines where racialized minorities had the highest rates of mortality. And it was really focused around where people were working and living. One of the stark images that stayed in my mind is the image that was on the front of the paper that showed the deaths from the NHS workers. And it was like immediately you could see that there's an issue. Like, why are there such high numbers of racialized minorities working in healthcare, dying from COVID? And that's when it really kind of became known to a lot of people that that's an issue. These groups were pretty much overexposed and underprotected. That's kind of the message there.
Thank you, Gwenetta. And final question. Harish, there are some for you, but I'll save them for later. Just one to Alasdair, if that's all right. Alasdair, are there lessons learned from the pandemic for older people receiving social care at home?
Can you repeat that, sorry?
In terms of the pandemic, were there lessons learned for how we managed support in social care for people who were receiving their care at home?
Yeah, I think people were caught by surprise. Well, everyone was caught by surprise by the pandemic, and I think there was just a lack of, it was a slow response and a lack of planning as to how this could be delivered. But I think also the monitoring of needs was just absent in a lot of people, and a lot of older people really suffered and went downhill and ate less. So I think there's so much to learn. I think just having coordinated responses and anticipating difficulties is going to maybe the big thing we need to learn from that.
Well, thank you very much. So thanks again to all four of our speakers. And we're going to hand over to our keynote speaker in a moment, but if you can just express your thanks to them. Thank you. So I'm just going to say a few words of welcome now to our keynote speaker, Professor Susan Hopkins, CBE. And we're really delighted, as Aziz said, that Susan's travelled up from London to be with us today. You'll be pleased to know that she had a warm Edinburgh welcome last night when we took her out for a bite to eat. As soon as I met her, the heavens opened. So by the time we got to the venue, we were a bit drenched, but she was very good-hearted about it. So Susan is the Chief Medical Advisor in the UK Health Security Agency. In this capacity, she leads the Clinical and Public Health Group, whose objective is to provide professional health security, clinical and public health leadership. From 2020 to 2022, Susan served as Incident Director and subsequently National Strategic Response Director for COVID-19 in Public Health England and was Chief Medical Advisor for NHS Test and Trace. She's also a Professor of Infectious Diseases and Health Security at University College London and continues to work clinically as a consultant in infectious diseases and microbiology at the Royal Free London NHS Foundation Trust. Well, I thought she had a brilliant title for her talk, so I'm really looking forward to hearing it. So please join me in giving Susan a warm welcome.
Thank you very much, Linda and Aziz, for inviting me to deliver this talk. I'm an esteemed company, so I hope I can deliver. The first thing I wanted to say was that when I was thinking about what I wanted to talk about for this talk, I was trying to think about many of the paradoxes that we'd had experienced in the pandemic. Things about who controls, who empowers, things about the role of the individual versus the role of the population, how we managed work, home, relationships, how we centralized versus decentralized, and how we thought in big terms about the various different populations and how we were managing old people, young people. And so all of these paradoxes sort of were coming together in my head, and we live with them on an everyday basis. And I started to think about, what happens when you go back in time and think about these paradoxes. And I was clearly spending far too much time with the British government and started to think about Greek and Roman philosophers. I looked at Zeno, and for those who know a little bit about Zeno, he's a pre-Socratic Greek philosopher who produced about 48 arguments revealing contradictions. Only 9 survive. And he was the first example, and you'll really see I've been spending too much time with British politicians, of reductio ad absurdum. So reduced to the absurd. And so I think it's quite useful sometimes for us to try and think about these, how the proofs were moved away from where they were in thinking about pandemics. So 2 paradoxes that I'm going to focus on in this. So I'm not going to go through all 9, you'll be delighted to know. And you actually know these, though you might have not realized that they were Zeno's paradox. The first is Achilles and the tortoise, also, you know, the tortoise and the hare. There's very many different examples used in the literature. And really, that's thinking about how we move from point to point. So if Achilles starts at point A, and the tortoise starts at point B, by the time Achilles has got to point B, the tortoise has moved to point C. And I really wanted us to reflect on that. At each point we move forward, what we're trying to do has also moved forward. And I'll give some examples in the pandemic on that, but as you know, you think you know what you're doing at this moment in time. You are focused on that piece of the moment, but you're not always thinking about the infinite possibilities that are out there in the pandemic future. And how do we think about protecting the old as well as protecting the young? How do we think about managing the racial disparities that we saw during the pandemic and treating people with equity and equality? How do we deliver on all of these different aspects? And that sort of brought me to the paradox of stasis, where when you look at the paradox of stasis, at each point, the arrow's at a single point, and each point is at a 0 as we go along. But in all, the arrow is moving. So how do you move this idea of reflection of the virus is changing, the population is changing their immunity, we're moving along in our pandemic journey, which is now almost 4 years later, but at each point, we're often focused on what's happening at this point in time. I think that's going to be really important as we look back in the inquiry to try and avoid what we call in medicine the retrospectoscope, thinking about what we know now and how we apply that to what we knew then. And that will be an important point in our thinking, is about trying to remember what we knew at that time and what we were trying to do and moving that forward. So to do that, I went back to my very first talk that I did in the pandemic. And this is a talk I did at the Royal College of Physicians in February 2020 with John Edmonds, a modeler who became quite well known for his modeling, and with Chris Whitty as the Chief Medical Officer. And at that point, we were doing a talk like this. It was in person and it was also virtual. I think it was the last in-person thing I probably did. And we were talking at that point in time about what the response was like and what we thought things were going to happen in the future. I was the incident director with Nick Finn, who now works in Scotland. I called him my incident husband because we worked hand in glove for 9 months, sharing everything together. And at that point, this is the mobilization of response that we had. And it was the largest response I had ever been personally incident director for, and it felt huge. Little did we know how insignificant this was going to feel just a couple of months down the line. At that point, almost 50% of our workforce, our infection-related workforce, were involved. Over the course of the pandemic, all of the workforce in PHE were involved. And we went and we increased our staff size directly involved in the response to close to 15,000 people, and actually employed many, many more, thousands and hundreds of thousands at testing sites around the country, at contact tracing centres, in delivery of the cross-government response, in developing vaccine and delivering the vaccine. And so it is really important when we think about these things to reflect on moments like this. And at that time, and I'm putting this up as this is what I put up on a slide then, with where were our gaps in our knowledge. And it really reminds us of how little we knew. We didn't really know what the key symptoms were. We didn't know if the disease was going to differentially affect populations. We didn't really know who was going to have the most severe disease. We had no idea about the role of asymptomatic infection in potential transmission or in potential outbreaks. We didn't know if there was going to be a vaccine. And I think, we look back and we think about the normality that the vaccine has brought. But at the time, that was by far the fastest development and delivery of a vaccine ever. We could still be here without a vaccine, without all of those works. And how would that feel if we were still having repeated lockdowns because of major waves of infection? I think many of us, and there's many of people in this room here today, who also learned a lot about communicating to the public, to politicians, to professionals during that pandemic. And again, I think for me, that was a huge learning about how do we do that? How do we step into that space? How do we recognize the importance of those communications that are done by professionals to professionals and to the public? We didn't really know about the NPIs. We had no idea of the longer term consequences, and I think that we still don't. We are starting to understand the longer term consequences on the psychological impact. We're understanding a little bit on the older age, racial disparities. Children, still understudied. What is going to be this lost generation, and how are they going to impact on their life chances over the next 10 or 20 years? But I think many of these questions we also do know now. And it just shows the value of science, the value of academics across organizations in the UK and globally working together to do that. But as a snapshot and a moment in time, it also tells us what we didn't know. And I hope this comes through, yeah. So from here, this is the sort of framework that we started to try and work through in Public Health England with academics, bringing information to SAGE. We started off with knowing very little on the epidemiology. We started to use modeling. Modeling was extremely important in those first decisions. As you've heard, antimicrobial resistance modeling is still extremely important. We started developing research, and the first research studies were critically important. And I think one of the things I would highlight at this point is that in thinking about the elements that we were doing then and the preparedness for the future, some of the most important aspects were where we had sleeper studies already in existence. I think Aziz had his EVE study, which was then able to rapidly mobilize. There was also the ISARIC study, which colleagues in the University of Edinburgh are also co-leading, which allowed clinical characterization of the individuals and allowed us to study what was happening to the virus and to the individual's immune response. And having those sleeper studies meant that we could activate very readily and quickly. And so as we go forward, we need to think through the research priorities and then ensure that we have a system to deliver them. We also thought about the place-based approach. So the difference of the Outer Hebrides to Edinburgh in Scotland was not going to have the same issues. The differences between inner city London, where people live in high-rise flats with no gardens, is not the same as somebody who has a lovely garden and can sit outside in it in the sunshine. And I think really trying to bring those things to the fore in the thinking about the future and what are the NPIs that we're dealing with is going to be very important. We talked a lot about behavior, and I don't think we always got it right. I think we need to acknowledge that. We actually got it wrong lots of times. But I don't think it was out of lack of foresight. I think it was out of a lack of having the ability to necessarily change things. And so what are those things that we might need to think about in the future? How do we make society more equitable and resilient in a non-pandemic so that we are ready and able to prepare for that pandemic moment when in a crisis, difficult decisions are very hard? Things like, do we have the right sick pay? Do we have the right way to educate children? Have we got the right social care system for the elderly? These are questions that are for now. They are not questions for the next pandemic. And unless we're thinking about how we make society more equitable, more just, more fair, in a situation where we have time to think and time to respond and time to make policy, it will be very difficult to change things in a pandemic. I would say then, all of these components of the top parts were things that science, academia, and public health were driving, considering, thinking about. But when it came to how it then translated, it was really important to bring those science advisories committees together in one way of thinking about how you bring the sort of insights from the specialist groups together into one spot. And that's where the role of SAGE, the Science Advisories for Governments, which I know you had your own in Edinburgh, but also in Scotland, but also that you came and attended the UK-wide one. Those are really important in gaining consensus, because at the time, we will only have limited knowledge, we will have to deal with it in various ways. We will as scientists, have contradictory views. But at the end of the day, we will have to have a shared view to provide ministers with the best advice and decisions possible. I'm showing this because we talk about the deaths by pandemic, and we talk about the COVID pandemic, and about 7 million people are reported to have died globally from the COVID-19 pandemic. That's actually, in terms of people who are looking at previous pandemics, quite a small number for some, and definitely a part of the world's population. So in preparing for pandemics, we must remember this is not likely to be the worst one that we may see in our lifetimes. It's also important when you look at some of these that it's not all transmitted by respiratory route. Sexually transmitted infection, close contact, vector-borne diseases are things that we also need to consider when we're thinking about pandemic preparedness. And yesterday, The Economist really happily updated their numbers on the excess mortality estimates globally. And I think when you see the excess mortality estimates, you really start to understand the global true impact of the pandemics. Really good to look at, and you can compare countries and look at it individually. And I think, again, this was something Sir Chris Whitty talked about a lot. It's really excess mortality that matters in the end when we look at the global impact and for our country impact, because the impact of pandemics is not just on the disease itself, but it's in all of the other diseases and conditions that we haven't been able to care for. And so that is a really important component. And you can see that the excess mortality here is in the order of 26 million as a point estimate, varying from 18 to 32. And we are still in the foothills of what we might see because excess mortality continues to be high. And that probably relates to the burden of diseases that we have not got. A couple of other points. So we've got a 7% increase in our excess mortality in the same time period as our COVID-related, our COVID mortality numbers. So we were counting quite well. In some other countries in Europe and globally have a much higher excess mortality. And the only one that I could see that had a lower excess mortality was France, who counted very well and actually counted a lot of their care home and social care deaths as COVID deaths when they may have died from something else. And so we're not seeing those in the excess mortality. So they're minus 10%, we're plus 7%, but there are many, many countries with many more excess mortality, and it's really worth a look. So I thought you'd bring you back to Zeno in case you've forgotten all about him. Really important in pandemics that we think about the force of transmission. And actually, I thought I'd remind people that one of the ways that the Zeno's paradox was disproved was by Weierstrass's a mathematician in the 19th century. And actually, it's maths that we use every day in stats and modeling, where you basically, for any number between 0 and 1, you can say 1 is the sum of those numbers, if the n is between 1 and divided by n minus 1. And actually, you can use this in trying to understand the small outbreaks that you might see and for rare diseases. Adam Kucharski from the London School did a really nice paper when I was looking up, has anyone ever said anything about Zeno's paradox and pandemic preparedness before? And he used it to quite nicely determine the R value for MERS, and the R value for influenza outbreaks that have never got very big. Because they're smaller and less than 1 and they fizzle out by themselves, you can use this simple disproving of Zeno's paradox to calculate 1. And I thought I'd just add that in to make sure people are awake. And so back to a little bit more about the tortoise and the hare, or Achilles and the tortoise. And I thought I'd highlight some of the things just again as progress, but how we can do it faster. So when we look at Spanish flu, for people who think about these things, the causative pathogen was identified about 15 years after the pandemic occurred. Of course, we didn't have a vaccine till the post-World War II, realistically. Really the antivirals that we now use were only licensed at the very end of the 20th century. When we look at HIV, which in my lifetime has probably been the biggest and most important pandemic before COVID, clinical syndrome was identified in 1981, but it took 2 years to identify the causative pathogen. And so that's really important in thinking about pandemic preparedness. Can we identify pandemic pathogens early? How do you know they're going to be a pandemic? The first drug took just a few years, but actually it took 15 years for really to have effective treatment. So we, again, in this pandemic, the fact that we had effective treatment and we knew what we were able to do and treat within a year with some drugs and within 2 years for very specific drugs was quite remarkable. All of this reminds me that in order to prepare, and it comes back to what Harish said earlier, we need to prepare now for new drugs and therapeutics. We need to think about the preparedness about what we're doing to try and predict what those pathogens might be and how we can therefore in advance have either platforms to develop drugs or platforms to develop vaccines, and also the trial infrastructure that we can do those very quickly. But at each point in the pandemic, we are thwarted by the virus changes. And I thought I would, again, bring this finite and infinite trade-offs into account. Because the viral evolution is likely to be infinite. It may not cause more severe disease. It may hit a limit about how immune evading it is, but I'm not sure. And we've got some virology and immunology experts in the audience who I'm sure could provide better commentary on that than me. But within those infinite evolutions, we are going to have to make finite decisions, as we're now all living pretty much back to normal, in a room together and talking about pandemic preparedness as if we have gone through this pandemic and it is in the past. But this virus is going to continue to live with us, and we're going to have to continue to try and keep up to some extent with it. And I remind us of the various different moments. I mean, I think that when we were in 2020 and the vaccines came along, we felt, hurrah, that's it. But it wasn't. We started to see immune-evading vaccines. We started to need new vaccines. We will continue to need new vaccines. We must recognize that in the first vaccine, it looked like we had a vaccine that prevented transmission, prevented mild infection and asymptomatic infection. But as the virus is evaded, the impact of those vaccines has got less and less. And the latest vaccine effectiveness data that we have and looked at very carefully is that if anything from the latest vaccines in the spring booster in the population who were boosted, they got a very limited impact on infection, a much longer and more prolonged impact on severe infection, but we don't have a neutralizing vaccine yet. So the war may feel like it is won, but it is not over, and we need to do better in the future. I thought I'd also highlight that in doing this and thinking about it in each moment in time, one of the things that we've really developed quite strongly is this a group bringing together lots of groups from different areas: genomics, modeling, epidemiology, virology, and immunology as well, where we look at the horizon scanning of what viruses might come through. We spent quite a bit of time over the last 6 weeks discussing BA 2.86, or Parola, as it's also called, but I'm not acknowledging that name formally. And one of the things that we do in this group is that we bring together lots of academic experts who are expert in all of this area and who are able to provide early insights into their data in a very rapid format. And we're able to develop a consensus view on the risk assessment of a new and emerging variant. These sort of collaborations are really important, and what we have tried to do is maintain them in peacetime, where we have regular catch-ups, because I think it took us quite some time in the middle of the pandemic to develop and establish and get the right people in the room, and for people in the room to trust each other in sharing very early data. And so having and developed that trust, what we need to do in a pandemic preparedness is maintain networks of excellence, and I know that the MRC in particular are funding collaborations of networks, and I think those sort of collaborations will be extremely important to link academic partners with public health and policymakers in order to get in advance of the future. I felt I couldn't do a talk about pandemic preparedness without mentioning at least a bit of the sort of my own personal work that I had done. And I'm just picking on Siren because it's been involved since the start. And actually, we're now thinking about it in terms of pandemic preparedness. So Siren, for those that don't know, was a study that we set up in May 2020 after we had done 2 initial pilot studies, one where we had asked healthcare workers would they test for COVID without having any symptoms. And we went in and in 10 hospitals, got 100 staff in each hospitals to randomly test. They were all in work, and we detected by PCR between 1 in 200 and 1 in 20 people who were positive for COVID on that particular day. Which told us that it was something that we needed to do better, and we needed to come up with better ways of understanding that. The second was that, as you will all know, there was so little testing in March and April that we didn't really understand who was immune and who was not. There was people saying potentially everyone's got infected and we didn't know, and only small numbers went into hospital. Or potentially there was very little immunity in the population. And again, as we know, and as was highlighted already by others, the healthcare workers were particularly affected. And therefore, in buying healthcare workers, we decided if we could look at the immunology of the healthcare workers and see how many of those were positive, then we would start to get an estimate from that. So we had done an initial study. And again, I'll bring us back to the Zeno's paradox of stasis to remind us that at each point in this study, I was thinking about now, or maybe in the next 3 months. I really didn't have the foresight in the pandemic to think about what it was going to look like in 2 years or 3 years' time. But as it went along, it evolved. And I think what I'm trying to highlight here is the various stages of evolution that we had to go through, and that we recognize that at each point we evolved into something new and different. So we first were there to try and understand what was the proportion of people who'd had a prior infection. What was the proportion of people that were getting infected on a weekly or bi-weekly basis? We then evolved into trying to understand, were people going to get reinfected? Because we didn't know the answer to that, and that was going to be critical. And then when the vaccines came along, we evolved to understand vaccine effectiveness in healthcare workers. And then as variants came along, we could reassess reinfections on variants, reinfections on vaccines. And that became extremely important in allowing us to understand the variation. We've now evolved, and our evolution from last winter, which was in pilot form, was studying not just COVID, but also influenza and RSV. And this year we have 5,000 healthcare workers. 6 of 8 Scottish boards are included, I'm delighted to say. So thank you to Public Health Scotland and NHS Scotland for participating. That we will then be able to study these individuals, looking at their immune response in their blood, looking at how many of them get vaccines over the winter, and how many of them get these respiratory illnesses. What we've also done, though, is added in a whole load of research collaborations. And we've got collaborations with a whole series of immunologists who are far cleverer at me in understanding the immune response to viruses, and where they take extra blood to look at the T-cell responses of viruses as well, embedded in the study. We've also got work happening with metagenomics, and I'll talk a little bit more about metagenomics in a second, with the Wellcome Sanger Institute, to see what else do these individuals carry, and does that make a difference? And finally, we are working with collaborations to see how this can help and understand and improve for vaccines, to improve the vaccines that can be offered to healthcare workers in the future. So we keep producing outputs, and from where I am right now, I want us to have a study that is scalable. It will be much smaller in size than we were in the pandemic, but that any way that we can then use that infrastructure for any new threat to scale up, expand within the system that we have already developed. So that is the plan for the future. And I'll skip over that, because that's sort of some of the results that we see. So we're here right now looking at surveillance. So we produce an output every 2 weeks, which we share with people to look at what's happening. We're doing core analysis. We've got an events of interest pathway. And one of the really good things that was coming from this is participant involvement. And many of these healthcare workers have never been involved in research. They're not They're not the research delivery people. And it's really helped them encourage patients to be involved in research. So they give some really strong feedback about how this is their first time being involved in a study. So I think sometimes we neglect the importance of thinking about our wider healthcare workforce and how we can engage them involved in research. And that can therefore promote research for other studies as well. So what else is happening? So the pandemic aside, we've had a lot of new threats over the last 15 years that have come through. Some of them have been small and managed very easily. Others have been larger. And the Mpox, for example, that occurred in 2022, we didn't know what the size and scale that was going to look like at the time. And so what I'm going to do now in a little bit is thinking through how do we and how can we prepare for pandemics by identifying pathogens earlier, and what are the tools that we are thinking about using. So the challenge we have here is that if you look at it globally, we're thinking about where something is developing in some other part of the world. That really needs global collaborations. We need to have global partners that we're working in. You can't do infectious diseases and pandemic preparedness in country isolation. It has to be global. It has to be considering where's the inequity. And if you look at some of the inequity in healthcare, much of that is in places where the pandemics are most likely to develop from because of the human-animal interface. And so I think when we are thinking about pandemics and we look at it, we shouldn't take a very UK-centric view, and we should think about how we're going to detect things in other parts of the world. Secondly, the bit that I'm in charge of or responsible for in the UK Health Security Agency is how can we detect something in the UK? And for that end, I'm going to give 3 case examples to say what can we do. So the first is looking at, these are the sort of ways that we think about detection. So the first is we look at global parameters. The second is that we look at Google trends. So we're constantly looking at Google to see who's putting in different symptoms. We use that actually to track influenza-like illness routinely, but we also use it to track rashes and infections and measles, and it's been found to be very useful where you see large outbreaks in parts of the world. In country, we both use what are individuals attending GPs for? What are they calling NHS 111 for? But for some of these, you need quite large-scale changes before you can really see them in the system. And I think maybe with artificial intelligence, we will get better at spotting the important minor changes, but they're quite hard. And we often focus on the latter 3, which is thinking about how we have well-designed studies to pick up things routinely. And for example, in GP sentinel surveillance practice. So in the start of the pandemic, the GP sentinel surveillance practices from the Royal College of General Practice detected the first community case in England. So that's individuals who presented with an influenza-like illness, and we took a sample and detected COVID from it. But we weren't routinely looking for unknowns in those. We were only looking for something that we knew. So it was only when we had enough PCR tests available could we even start doing it. The second way of doing things is through the clinician suspects something. And that, as you know, is how we use many of the things at the start of COVID. And many of the diseases that we see, it often is a physician suspecting. And finally, we could have use of things like metagenomics in a panel of tests in the health service so that it would allow us to find the unknowns as well as the knowns. A nice example is acute severe hepatitis in children. Again, this was really important work done by colleagues in Scotland with Emma Thompson from CVR. And what she was involved in is trying to understand what were the causes of these acute severe hepatitis in children. And what we looked at here was trying to describe whereabouts would metagenomics happen and whereabouts could it help us. Global intelligence didn't. We were the first country to report it. Behavioral indicators with such small numbers of severe disease weren't going to help us. The routine clinical testing would have discarded a single pathogen as the cause, and many people did discard single pathogens and do discard it. And it was only when we looked at the metagenomics of what was in the liver and what was in the blood of these, and we could show that it was a combination of viruses working together, that was really important. And the other really important aspect that we also did in this was looking at the human genomics and understood that it was a combination of these two viruses as well as a human genetic factor that predisposed, all coming together, that it caused acute severe hepatitis in children. But actually identifying that and knowing that meant that we could start to actually look at the action. People could think about it as individuals arrived into hospital with this so that we could manage it appropriately. In the example of monkeypox or mpox, the clinician suspects was actually the piece that was probably most important in actually finding it in the end. But the challenge with it is that the clinician suspects, if you don't have a diagnostic test for that, whatever they suspect, can still take quite some time. And so when we went back and looked through a number of records in the previous 4 to 8 weeks before the mpox was actually diagnosed, there were a number of individuals who had been treated for herpes, for gonorrhea, for syphilis, who they had been given multiple courses of antibiotics and antivirals. And actually, if we had used something like metagenomics, it would have helped us much earlier on. Designing syndromic surveillance studies for metagenomics at this scale probably wouldn't have helped us, as when we went in and talked to the STI clinics, we would have had to look at about 50,000 people to find this rare disease. But using the clinician suspects and then having a pathogen agnostic approach could really assist. And finally, for COVID-19 and where we're going in the future. So for COVID-19, we talked about the first case being in RCGP once we started testing the RCGP. So within a week of testing the GP samples, we found it. Within a day of testing ICU samples, we found it. And so that does not necessarily say that it was sitting and floating around in ICU or primary care for a long time before. But it does say to me that when you have surveillance that is representative of the population that you're seeking, either in the community or in the primary care or in secondary care, that we really need to think about approaches that are pathogen agnostic, that would allow us to devise a range of known and unknown pathogens in order to detect things earlier. Detecting things in communities or detecting things in ICUs earlier than we did in this pandemic may have assisted us in having better control measures. Can't say for definite, we can't go back in time, but it's things that for the future we should be considering. And the final example that I'm going to give is foodborne infections. It's a bit of a flavor outside it, but I think something again. And when we think about how we detect a foodborne infection outbreak, we find individuals, people with gastrointestinal illness, we test them. We only test the tip of the iceberg, so it's usually only the really severe cases that get a diagnosis. And then we go into detailed studies trying to figure out what is the causative agent in that GI outbreak. So this is STEC, so Shigella toxin E. coli, producing a bloody diarrhea and can produce a hemolytic uremic syndrome outbreak that we saw last summer. And when we looked at this, it was really explosive and really quick. And normal investigations happened, where you do this really complex investigation, where you interview every case and you look at every single product they've eaten, where that product could have come from. You go back and you interview the restaurants they've eaten in, you find out all the products. You end up with this complex map, where you then start to triangulate where the most likely overlapping products and food are. And so with the whole genome sequencing, the case onset data, and all of this product data, it was put down to a UK food, and a grower was implicated. And at the time I was like, this seems really laborious and doesn't really help us. By the time we'd done all of this, the outbreak was over. So you have all of these people coming to harm, and you really, it's an academic exercise after the fact. Now in some cases you can detect things longer. But what I was interested in is, well, we know where we have this bacteria. It lives in in the guts of sheep and animals. So can we go upstream? Can we think about what is the hypothesis? How is it getting into our food? And so we did this piece of work with one of my fellows where we essentially found out where this grower was, and we've since done some backwards work, but I'm just going to give you this example. So we looked at the areas where the grower was. We looked at the flood risk map. So that means that sheep are pooing up the hills. The sheep poo comes down the hills onto the food, but it's more likely to sit on the food if there's lots of floods. and there's lots of rain. And so we looked at the rain anomaly map for that period of time over the period of summer, and we were able to detect that there was clear rainfall anomaly in this area. And then we overlaid that with the grower and the food and the land produce description to try and describe this. And then we're actually able to bring all of those together to identify X marks the spot. And so we've now used that in reverse to detect a strawberry outbreak. So we basically had an outbreak of STEC this year. And what we did was, the minute it was detected, I was like, okay, can we run this in the reverse order? And the fellow was able to use the exact reverse order and to determine that it was likely to be strawberries from a production in X spot, and was then able to reassure me was that they hadn't supplied Wimbledon because it was just at that period. But I think we can move this faster and do this in an automated way so that we move ourselves from thinking about infections right up to the source and where we go from there. So I'm almost at the end, and I thought that in giving you those examples, I thought we'd come back to the preparedness response paradox. Much of that's been discussed. There's been lots of discussion about how UK was supposed to be brilliant at preparedness, but did really well and badly in response. And so I think that there's always this challenge on how well you think you are prepared, what you think you're prepared for, and how you're going to manage the next threat that comes along. And if we go back to the Zeno's paradoxes, is that once the threat has occurred, we know what we need to respond to and can deal with it. But in the middle of it, and at the time and before, we're in a never-ending race and battle between what we know, what we're trying to deal with as the business-as-usual components, the ongoing public health threats around us, and the unknowns of what may happen in the future. And it is only when the tortoise crosses that line that we know whether we've actually managed to achieve preparedness for that threat that we have now suddenly got in front of us. That should not make us upset. The other way of thinking about it is that no matter what the thing that you're doing, the first time you do it, you're only half as good as you think you'll be at doing it. The second time, you'll be better again, and so on and so forth. So again, in a sort of Zeno's paradox type way, that each time you will improve. You'll improve half as well as you did the previous time. You'll never quite get to the perfection that you thought it was going to be, but it's good enough. And it's that good enough that we really have to start thinking about and preparing for. And so in doing that, these are the sort of 6 activities that we are working on as an organization. I've talked a little bit about the rapid detection of novel and emerging pathogens, a little bit about the studies that we need to have clinical characteristics of disease, transmission modeling. Lots of work in improving our monitoring and surveillance, our genomics, our data sharing, which should not just be insular inside the UK, but global. Work on non-pharmaceutical and pharmaceutical interventions. Thing that I haven't touched on, but really important, is how we think about collaboration and workforce, because I think we need to be able to have individuals who can move fluidly between clinical, public health, academia, and industry if we are trying to really have a resilient population of individuals who can respond. And finally, as I've touched on in various parts, the health inequalities have to be dealt with all the time in order to give us a population resilience and to reduce the impact of diseases on the population. Thank you.
Very much, Susan. So I'm going to invite Paul Johnston now to give a response to Susan's lecture, and I'm just going to introduce Paul and tell you a little bit about him as well. As you know, Paul is Chief Executive of Public Health Scotland, and he was appointed to that role in March 2023. Prior to that, Paul spent 8 years as a member of the executive team and corporate board in the Scottish Government, and his responsibilities covered, as I know, having worked with him, many areas of social policy that have a direct relationship to health. That includes being Director General for Education and Justice, and most recently in the Scottish Government, he was Director General for Communities. And the areas that Paul was responsible for were social security, housing, equality, human rights, local government, and public service reform. And by background, he's a qualified lawyer and joined the Scottish Government in 2000. So I was absolutely delighted when Paul took on the role of Chief Executive in Public Health Scotland. I think he's got a really relevant background, and I know he'll be sharing his thoughts with us for about 10 minutes in response to Susan's lecture. There will be an opportunity to ask questions, so if you want to ask the Chief Exec of Public Health Scotland a question, this is your opportunity to stick it on Slido, as well as the ones you popped in there for Susan. Paul, thank you for being with us.
Well, good afternoon, colleagues, and thank you very much, Linda, for the introduction and indeed for the time warning, which I am duly noting. But huge thanks to Susan for that presentation that I'm sure we've all enjoyed enormously this afternoon and all learned so much from. As I've been looking at Susan's work and indeed having a conversation with Susan over dinner last night, I began to reflect on both the what of the work that we've all learned about, but also the human dimensions that we haven't really touched on so much today, but that I think are so relevant to what Susan has brought to us and what so many of you have shown in your work and in your leadership throughout the pandemic. And two words that particularly strike me are, first of all, the word courage, and secondly, the word vulnerability. During the pandemic, when I was in the Scottish Government, despite the pace of work that I and the team I was with were working on, I was so conscious of the human cost, the human impact of the work. And at points we managed to take a few hours away from the work and just look at how we were working together. And we were particularly helped by the work of Brené Brown, which I'm sure many of you have come across. Let me give you one quote which just came to mind as I reflected on Susan's work and on Susan's leadership. Brené Brown says this: "The courage to be vulnerable is not about winning or losing. It's about the courage to show up when you cannot predict or control the outcomes." And she goes on to say, if you choose courage, you will absolutely know disappointments, setbacks, and even heartbreak. That's why we call it courage. That's why it is so rare. So Susan, on behalf of this audience, can I thank you for your leadership and for the courage that you have demonstrated throughout the pandemic in supporting this country and other countries learn and get to where we have got to. And can I thank so many of you in the room, Aziz, Linda, and many others here, for the courage and vulnerability that you have shown in recent years that have enabled us to make such progress. Let me say just a word from a Public Health Scotland perspective about what we are seeking to do to ensure that we contribute to pandemic preparedness. But then, colleagues, I really want to use the remainder of my time to ask us to look at the broader picture in terms of what's going on with health in Scotland right now. The COVID-19 pandemic did, of course, inspire fantastic collaboration. Susan has referred to the work of Siren, and Susan indeed was chief investigator for Siren, and her vision and leadership of that work was vital. Similarly, EVE2, which has been referred to, linked the UK's world-leading vaccine programme with Scotland's ability to link clinical data to show the real-world impact of COVID-19 vaccines. We're now working in Public Health Scotland with partners, including the UK Health Security Agency, to ensure that we're as well prepared as we can be for future pandemics. The Standing Committee on Pandemic Preparedness, established by the Scottish Government in August 2021, has recommended that work is undertaken on the development of a Centre for Pandemic Preparedness. And over this summer, Public Health Scotland, along with other partners, have had more than 250 conversations with a very wide range of people from across Scotland, and will be reporting back to the Standing Committee on Pandemic Preparedness later this year on our findings. But it's very clear that we must build on our strengths in Scotland in data and analytics. We must develop increasingly strong links across the UK and with international partners, with scientific advisory structures and with networks. We must support continued innovation in life sciences and in public health for the development of diagnostics and vaccines. We have so much strength in Scotland, so much learning from the pandemic, and now it's our responsibility to take that forward as we seek to be better prepared for the pandemics to come. But let me say something now about Scotland's health. And here I was particularly struck by Susan's challenge to us. She said, how do we make society more equal, just and fair while not in a pandemic, in order that we might be better able to respond when we are in a pandemic? So how are we getting on in terms of Scotland's health? How are we getting on in terms of making Scotland more equal, just and fair? And their colleagues, I'm afraid the data and evidence in this, the age standardised premature mortality rates among under 75s shows that we have a huge amount of work to do in Scotland in order to see much needed progress. Within public health, I think we like to be optimists and people who express possibility, and there's plenty of reason for that, given that this diagram demonstrates, or this graph shows, that between the start of this century and 2013-14, we were seeing progress with Scotland's health. We were seeing early deaths and inequalities reduce. But look at the stalling of improvement and then the increase in early deaths that we've seen in recent years. Of course, attributable in some part to the pandemic. But I think we're all clear that it's poverty and inequality that is leading to a much greater loss of life in Scotland today than even in the height of the pandemic. And we're particularly concerned to see that flaring out of early deaths and inequalities among the poorest 20% of the population. So at the heart of our work within Public Health Scotland now and in the years to come is looking at the range of actions that must be taken in order to improve Scotland's health in the round. This graphic adapted from the King's Fund, and I'm conscious in speaking to an esteemed audience that some of you may wish to quibble with the exact percentages, so let me emphasise that these are estimates and they are not intended to be precise, but broadly they set out the range of factors that must be taken into account as we work together in partnership to improve Scotland's health. And on the right-hand side, you see some of what we would identify in Public Health Scotland as promising and necessary areas of work that must play a part in addressing Scotland's health challenges. And we're working with both the Scottish Government, with our partners in NHS Scotland and with local government to see where we can really intensify and sustain work to tackle poverty, to address health behaviours and their impact, in particular alcohol, drugs and access to healthy foods, and where we can support the current health system to address the pressures that are faced, in particular through the contribution that healthcare public health can make. And as I close, let me simply share with you a very live update into how we are organising ourselves in Public Health Scotland, and really extend an invitation to you here to work with us as we seek to ensure we have a really clear focus on the programmes that we believe will lead to the greatest improvement in Scotland's health. And we have here a range of programmes. I'm not setting out a structure chart in traditional directorates, because I'm very clear we need to work across boundaries and with our partners, including partners in the Usher Institute and in the UK Health Security Agency. Right at the heart of that, we must work on vaccine preventable disease, on health protection, incidence, hazards and response, on disease registration and screening. But will you work with us, please, colleagues? Will we work together when not in a pandemic on early years and young people, on rates of poverty in Scotland, on public mental health, on place and physical environment, on equity and justice, and on health-harming commodities and more. Please see Public Health Scotland as a partner with you all, as together we work to see improvements in Scotland's health now and better preparedness for any pandemic to come. Thank you so much.
Well, thank you very much, Paul, and thanks to those of you that have put questions in Slido. So we do have a few questions, and a couple of these, I think, are relevant to the words that Paul has shared with us, as well as Susan. But Susan, I'm going to ask you the top-ranked question first, and I think this is an important one for all of us who are working in different roles through the pandemic as we move away from it and we speak to people in our communities who are still really badly affected and maybe don't think the response now is right. We've moved too quickly. So this is a question from Ellen. And she asks, how do we balance moving on from a pandemic as normal when vulnerable communities and those with long COVID are still left largely affected?
Yeah, I think I tried to touch on that in the sense that I think we're only starting to understand the impact of the longer term impact of COVID. I'm very keen that we work collaboratively across the health agencies, but also with academics, to actually really understand what that is, to really help and develop the future ways of working, so that when we think about pandemic and illness, we don't just think about the acute response. I mentioned HIV. I mean, HIV has been a pandemic for 40 years. Causing global problems and global health issues. And so we can't just call it and manage it in the acute response and say it's done. For many of us, we'll continue working on the response to it and the legacy from it for many years to come.
No, I think that's right. So I'll ask a question to both of you next, which I think is relevant for the role of Public Health Scotland as well as the work that you've been doing, Susan. So Richard has asked, as well as preparing science for future pandemics, we must also prepare the population. So how do we foster a greater trust in science and its outcomes? And that probably includes public health agencies. So Susan, if you want to respond first. And then
So first, I mean, I think that there's a variety of ways of doing it. I think having public forums to discuss it, having scientists willing to come out and talk about their work to the public, fostering relationships with journalists so that we get the right media reports in. The Science Media Centre do a great job. I think we should do more of it. It was really active during the pandemic, but we have to work on that. Having honest conversations about the value of research and the fact that often research is not valuable for you as an individual, but for society as a whole. Having conversations about the value of data and why we use data and how we use it and how safely we use it. Those are all things that I think we have to be doing honestly and openly if we want to bring people with us. And I think we need to build the evidence for the harms and lacks of harms. And when there is a harm, we have to be open and honest about it as well, so that we're not seeing as hiding things. We value transparency in our discussions.
I agree with all that Susan has said. Let me give you one example of current work that we are involved in Public Health Scotland, which I think illustrates some of what we need to see here. And it's our work on minimum unit pricing. It's topical, it's been controversial, but what I'm struck by is the extent to which we have led work in partnership with many academics in Scotland and beyond over a period of around 5 years, so it's not been quick. And we've now been able to produce really robust evidence. Of course, there is nuance in it, we would expect that, but we have evidence that we can absolutely stand behind, discuss with confidence, and in so doing, we hope, influence public policy in terms of the way ahead. I think it'd be a great temptation to say we always want things done quickly. Certainly part of my learning is the need to take time and to work in deep collaboration in order to come up with evidence that is really robust.
And let me ask you a follow-up question, Paul, which touches on some of the themes that are in the questions here. And then, Susan, I'll come back to you with a question on HIV/AIDS, which I think is really interesting. So, Paul, I know you've been responsible in your time in government for a lot of work on COVID recovery, working jointly with local government and national government, and a lot of reflection about actually some of the good things that happened during the pandemic. So I wonder if Susan's given us a scientific perspective on that, but from a systems perspective, what did we do well and what should we try and retain?
Yeah, great question. Thank you, Linda, and thank you to those who have asked it. There is so much learning, so much that we did well. I'll say it since Linda may be too modest to say it. Linda chaired in government our advisory group on children and young people, and I personally feel proud of the way in which we did give priority to the rights of children and young people, and I think part of the learning is around the absolute need for that, and there'll be many words used around the inquiry, but I certainly think we've got important learning around children and young people, the importance of play, of social contact, and of course of protecting and preserving their education wherever possible. There's so much I could say, but one further area that I would mention, I think we saw the power of dismantling boundaries and barriers between organisations and focusing in on getting the support that individuals needed straight to them as quickly as possible. And I know that there's now a real focus in government and within the NHS on what increasingly an approach to person-centred, non-siloed support will look like. It's not easy, given different bodies and accountability, but we know we need to get support rapidly to individuals when they need it most, in some ways regardless of which organisation they first contact or reach out to. Important learning that we must take forward.
Thank you, Paul. And Susan, a question for you from Jamie Garcia. So he said, how has COVID changed how we think about HIV and the lack of a vaccine for it? How can we look back at previous pandemics with new learnings?
Yeah, so I think HIV and the complexity of trying to find a vaccine highlights the challenge that we might have with a future pandemic, so that we may not have a luxury of a vaccine. I think what has happened with COVID, and equally what happened with HIV, is the huge amount of focus of researchers looking at the same direction to help solve a problem. In HIV, that was particularly focused on developing therapeutics. It also looked at vaccines. It just wasn't as successful in that area. But I think what it shows is that when we put a huge amount of effort into trying to solve a solution together from many different aspects, we are much better at it than when we have lots of things happening at a small level across it. You just don't have the same momentum. And of course, you need the breadth, but also you need the focus and depth in solving problems. And perhaps with the range of therapeutics that we now have for HIV, perhaps for the fact that people can live lives fully and normally living with HIV is there, that the focus on a vaccine has gone off the boil on it. But I think that's where prioritization always takes the place in research and in health as we go forward.
So we've got time for a couple more questions. I'll ask the next one to both of you. And again, this is the top rank from the ones that are still left. So maybe to you first, Susan. So how do we stop governments disinvesting in pandemics, in pandemic preparedness, now that we're through the worst of COVID-19? Now, you talked about the scientific, a lot of the things that we've learned. Paul also talked about the Standing Committee on Pandemics in Scotland and the Centre of Partnership for Pandemic Preparedness. But I think this question is slightly different. As we look ahead, we will have plans, recommendations. How do you keep making the case for those elements to be maintained?
So I think it's challenging. And I don't think we should shy away from the challenge, but I think we should recognise it. Governments have a set of resource that is limited with a whole load of competing priorities. And right now, if you look at some of the competing priorities that are on it, related to energy crisis, related to financial crisis, relating to interest rates, they have to balance those up with the health threats and the health recovery. So I think one of the things that I've learned in working much closer with government is that you have to recognise the whole compound of areas that they're looking at and trying to respond to. However, I would say that lots of different components of the work is about preparedness, but we don't always see it in that way. So how do we prepare our workforce? How do we work in inequalities in general? How do we think about how we are improving the care for older people and younger people in general in the population? And how do we work as a whole of government to improve the health? So coming back to some of the points that Paul made, are all in preparedness. And then we need to ensure that we're investing in some of the high value or high risk areas. And of course, the UK government has invested in ARIA, which is sort of high risk research component. Some of that will help us, but we have to recognize that we have to fix some of the problems that are in front of us at the same time.
I think all I would add is that between us, I think we need to make very clear the case that investment in improving Scotland's health is absolutely vital if we're to secure a flourishing economy and long-term prevention of greater harm. Public Health Scotland, in partnership, again with others, it's a theme here, produces work on the anticipated burden of disease that Scotland faces. And unless we really invest in improving health, the projected burden of disease would anticipate diseases rising over the next 20 years by around about 1/5, partly or in large part due to demography, but for other reasons as well. So I think we can make a very clear case that looks at the range of investments needed to protect health and shows that ultimately that is necessary investment that will save money now and in the longer term, and will help grow our economy. There's something about the dynamic between health and the economy that we haven't had an opportunity to touch on much here today, but I know a great deal of work is being done on it, and I think we must build that case, Linda.
Well, let me ask you, Paula, a slightly related question, which again is now at the top of the list, and then Susan, I've got one final one for you, and then we'll conclude. So as you think about that projected burden of disease and the demographic changes that we have in Scotland, Paul, we all know that the current investment we have in our care system is probably not sustainable to reach that need. So a really important sector is unpaid carers. And we've got a question here about the fact from Richard Mead that there are 800,000 unpaid carers in Scotland, and unpaid care is a social determinant of health. So what more can the government and Public Health Scotland do to really support that unpaid care sector?
Yeah, thanks very much for the question. You're absolutely right that there's such financial pressure on the health and care system that we are absolutely reliant on the support that unpaid carers offer, Linda. As colleagues here will know, there's a great deal of work being done on the future of the care system and the potential for a national care service. But what is clear, and I'm sorry if I don't have a good answer to this, what is clear is that while we need to properly reward those who are providing care as their professional role, and there are big issues there, and it's a clear priority of government to do so, at the same time we must value and support unpaid carers as best we can.
Thank you. And Susan, just a final question for you, and of course this has been in the news a lot, and people in the room will be coming forward for their influenza vaccine this winter, and for some, the COVID vaccine, but not for the groups that we might have expected. So the question is, can you tell us, and I know I know you're not responsible for this, but you'll be familiar with the roles of the organizations that are. Can you tell us a bit about the modeling that was used that led to the decision not to offer boosters to most people under the age of 65 this winter?
Yeah, so the modelling's been published. So this was modelling done by the department in support of the Joint Committee for Vaccination and Immunisation. And it predominantly, as does for all vaccines, look at the health outcomes. So quality adjusted life years, disability adjusted life years, and health harms. I think there is, where that's coming from, I think is, there's a whole population who are not going to get vaccinated. I think we have two challenges that I did touch on in the talk. One, the current vaccines that we have don't last very long in preventing infections, maybe a couple of months. So if we really wanted to prevent infections with vaccines as they are right now, we'd be vaccinating people multiple times in a year. That's not going to work. We're not going to get people to come forward. Secondly, the people who have the most health gain from vaccines at the moment are the people who are older age groups and severe disease, and that's why they're being offered, those with underlying conditions that can cause severe disease, and that's why they're being offered vaccines. I think as vaccines emerge and continue, and if there is a neutralization vaccine that protects everyone against infection, or one vaccine shot that hits all, as we have for many other vaccine-preventable diseases, that may change. But at the moment, there's always a sort of cost-value judgment in all vaccination programs that we develop and deliver. And that is on who gets the most health benefit from it. I think there is a discussion, and a wider discussion, about health and the economy, and how do vaccines play in keeping people in work, and how do vaccines prevent long COVID. But I'm afraid we don't have the answers on those yet. And those are things that will need to be discussed in future if we are to change how we cost and deliver vaccines.
Thank you, Susan. Well, apologies to the colleagues whose questions I didn't have time to pose. There will be some time for discussion, viewing the posters and exchanging information afterwards. So I hope we'll be able to discuss some of those things informally. But I'm going to hand over now to Professor Christina Boswell, who's Professor of Politics here at the university, but she's also Vice Principal for Research and Enterprise, and she's going to give the vote of thanks. So thank you, Christina.
So thank you very much to Linda, and I'm really delighted to be giving the vote of thanks to Susan and to John for such a stimulating, informative, really fascinating lecture and response and discussion that we've just had. Now, I should say this is the first time I've attended an Usher lecture, because I've been in my role for just 1 year, so I can't speak for previous lectures, but I can't think of a better set of speakers and a topic to really express the spirit of the Usher Institute and you know, returning to some of those themes that Aziz mentioned at the beginning. So I think what we've discussed today and what we've heard from our speakers really manifests 4 key features of Usher. And the first is this absolutely deep commitment to addressing urgent public and population health challenges, in this case, of course, a global and major global crisis. And I think, you know, as Paul put it so well, it demonstrates a humanity, but also a level of courage and vulnerability to sort of expose yourself and you know, show that deep commitment to addressing those sorts of major challenges. And then I think, secondly, in doing so, what's demonstrated is that you really have to harness whatever resources, whatever knowledge is relevant to addressing the complex problems that you have. So I think, you know, you really demonstrated how we needed the full range of disciplines and approaches. I mean, you know, even stretching to pre-Socratic philosophy, who would have thought, Susan? So that's another key feature of Usher. I think the third one is the importance of partnerships. So we need to work together across public health and policy, with patients, with the media. We have to dismantle barriers. That was a theme that came across in Paul's comments. We need mobility, as Susan was talking about, and sort of flexibility to work across these sectors. And then I think the fourth and final point I wanted to mention in that respect was that this isn't just a narrow focus on a one-off crisis. You know, this particular crisis shone a spotlight on a wider set of underlying social, economic issues and inequalities. And some of the most important learnings from this crisis, I think, relate to how we address and prevent those broader issues. So, I mean, Susan noted that she is an illustrious company in delivering this lecture, but I can't think of a more qualified lecturer to be invited to give this lecture and a more sort of specialized and qualified respondent to this. So thank you. If you could join me in thanking our speakers for a fantastic lecture and response. So just a very small token of our gratitude. So the second thing I've been asked to do is to announce the prize winner of the poster presentations. And we actually have our 5 shortlisted poster presenters sitting here in the front row, I believe. So if you'd like to just stand up and say hello to the audience. Well done. Now, of course, very, very difficult to choose a winning presentation from such strong posters, and you can go and have a look at the posters if you haven't done so already in the lobby downstairs. But obviously the panel did have to take a decision, and we'd like to announce that the prize goes to Jurgis Kuliesius. So congratulations to Jurgis. And the third and final thing I'm going to do, I'm not going to keep you much longer, but before handing over to Aziz for some closing remarks, he doesn't know this, but I'm taking this opportunity to say a few words about Aziz, as this will sadly be the last Usher annual lecture that you will attend, Aziz, as director of the Usher Institute. But we do hope that you will be at future ones, perhaps as a speaker yourself. Now, as many of you know, later on in 2024, Aziz will be joining the University of Oxford. They're very lucky to have him, and we wish him well in his new role. But we're delighted that he's going to be retaining close links with the Usher. I know Usher through his remarkable contribution to research, his path-breaking work on Eve and Eve 2, his transformative analysis of Scottish and now UK health records to understand and improve population health. But I also know from Aziz's colleagues that he's a wonderful and much admired and loved institute director. To quote one of his colleagues, Sarah Cunningham-Burley, who unfortunately couldn't be here, she's actually laid up with COVID, but she says Aziz is full of grace and humility, and he promotes inclusivity through his leadership. He's ensured that as Usher has grown in size and reputation, it's done so fully recognizing the value of all the disciplines that make up population health sciences and the value of all the staff and students who make up the Usher, whatever their role. And Sarah says, in addition to making such a major contribution to public health himself, especially through the pandemic, Aziz held all of us as we navigated those difficult years. The exciting times ahead have been made possible through Aziz's leadership. So I think that's wonderful testimony to Aziz. So on behalf of Sarah, who couldn't be here, and the Usher, on behalf of the university, I'd like to thank you, Aziz, for everything you've done and will continue to do on behalf of all of us, and for what you've done for population health and primary care nationally and globally. It's really a remarkable achievement. So with that, can I hand back to Aziz? Thank you.
Thanks so much, Christina. So I've got the sort of privilege of just saying the last few thank yous, and really we don't do this enough, but just heartfelt thanks, first of all, to Susan and Paul. Not only for sort of outstanding lecture, Susan, and a response, Paul, but really for your friendship and your leadership over the last few years. I think we've all got a bit of PTSD that we need to have sorted out at some point. That's what we were discussing earlier. Yeah. I want to thank Linda, absolutely fantastic chair. Linda's been involved in sort of setting all of this up. So thank you so much, as ever, Linda, for your support and leadership, really. So Sarah was due to do the vote of thanks. We sort of exchanged emails with Christina late last night, And as ever, I mean, Christina sort of stood up, absolutely wonderful, and really sort of inspirational leader. So Christina, thank you so much, really, as well, really, for stepping in and for your sort of kind comments in relation to our speakers, and really more generally in relation to the Usher as well. Thank you. Okay, we got a bit of a taste of what's going on in the Usher, so delighted that Gwenetta, Harish, Katie and Alasdair presented. There were a number of colleagues presenting in the showcase, the posters. These all involve a lot of work from a number of colleagues, really, so many, many thanks to them. To Katie and Miguel, who were judging the posters today as well. So, I mean, thank you to all of you guys as well, really. Appreciate that. The Usher Institute, I mean, as I was mentioning, has had a long history. This has been built by absolutely fantastic colleagues contributing now still. And I want to just mention that a few of our emeriti professors are here. And I used to get this wrong, but ChatGPT corrected me that the plural of emeritus is emeriti. So, I mean, at least I've learned that. But got Amanda Amos, Raj Bhopal, Jerry Folks, Scott Murray here as well. So thank you really for everything that you've done, because I mean, hopefully, I mean, whoever comes into position will continue to build on this fantastic trajectory. But I think we always need to remember sort of where we've come from and the people who've contributed, really. So thank you as well. Thank you. Okay, so finally, I mean, this event has taken absolutely months of planning, and I want to single out, I mean, a few colleagues in that respect. So we've got Vision Events, Catalyst, the University of Edinburgh Hospitality and Events Collection, really for their support. But our comms team in the Usher is absolutely fantastic. And that work has been led by Laura, Susan, Sarah and Dawn. And really pleased that we've had a student joining us from Queen Margaret University, joining our event management team, Eve. They give us really detailed notes. So, I mean, Linda was just reflecting that she's told to stand up at, I don't know what it was, 1:21 or something. But I'm going to go off-piste and just ask you guys, I mean, these are not in the notes, but please do just stand up and thank you, really, for everything that you've done. Thank you. They're a class act, so I've got just a few things to... So, I mean, we want your feedback on the event, and please just tell it as it is. That's the way we get better. So things that have worked, things that haven't worked, we want to hear. So you can do it from that. After this, I mean, please do, I mean, if you have time, there are some refreshments downstairs. It would be great if you could meet with our colleagues who put together the showcase and presentations. Those online, please do have a look as well. I just wanted to flag a couple of coming events. So we have this New Frontiers in Health and Social Care. So a number of presentations coming up there. So please do, I mean, if you're interested, do come and support that. And I wanted to particularly highlight the Women in Healthcare Data Science, a really important one, and delighted that our new co-head of the Centre for Medical Informatics, Julie Jacko, joined us from Florida last week and is investing in Wellington boots and an umbrella at the moment. We'll be presenting there. And then what we've got are some inaugurals coming up, and delighted that Harish will be presenting as well. So thank you everybody for joining. Thank you everybody for joining online. Finally, thanks again, Susan and Paul. Absolutely fantastic. Thank you.